in the last section of Chapter 11, we talked about nociceptive chronic pain. And we said that it serves a useful biological function, and it's caused by stimulation of nociceptors, continued stimulation of nociceptors. And the only way we're going to get rid of it is if we get rid of that stimulation of nociceptors. Well, in this first part of Chapter 12, we're going to talk about neuropathic pain, and we're going to discuss a few more of the symptoms of chronic pain. So, in the end of Chapter 11, we talked about primary hyperalgesia, where the nerve endings, those free nerve endings in the periphery, are sensitized and they're more sensitive to normal stimuli. In this section, we're going to define paresthesia, allodynia, dysesthesia, secondary hyperalgesia, and central sensitization. So you can think of primary hyperalgesia as being part of nociceptive chronic pain, and these are all part of neuropathic chronic pain, and we'll define what they all are. I want you to be able to describe the symptoms and presentation of complex regional pain syndrome. So when we start talking about pain syndromes, which is all the rest of the learning objectives on here, that is the second lecture in Chapter 12. So I want you to be able to list the factors that contribute to chronic low back pain syndrome. I want you to be able to compare the signs and symptoms of different types of headache, migraine headache and episodic tight tension headache, and chronic whiplash-associated disorder. So that they all have specific symptoms that differentiate them from one another. And I want you to be able to describe the signs and symptoms and pathology of fibromyalgia. So in the second part of Chapter 12, we will talk about those specific pain syndromes. In this part, we're going to talk about chronic pain as disease. So we've talked about in other courses the difference between acute pain and chronic pain. So acute pain involves the threat of or actual tissue damage. So the threat of tissue damage or actual tissue damage. Chronic pain, nociceptive chronic pain, which we talked about in the last chapter, can come from continuing tissue damage. There's something that's still present that's damaging the tissues. It can come from environmental factors, sensitization of nociceptive pathway neurons, or dysfunction of endogenous pain control systems. And so when we're talking about neuropathic chronic pain, that's where the dysfunction part comes in. With acute pain, the client or patient is going to report a clear description of the location, pattern, quality, frequency, and duration of pain. Chronic pain is going to have a more vague description, and people frequently talk about how they feel the pain is moving or spreading with chronic pain. The way that acute pain affects your function, it's a warning of tissue damage, and its biological function is to enforce the rest of the tissue so it will heal. If you don't have continuing tissue damage and you have chronic pain, there's no biological benefit to resting, even though there may be a social or psychological benefit. And so sometimes chronic pain, that social or psychological benefit becomes more of an influence. The consequences of acute pain, you have excessive autonomic activity, you have excessive neuroendocrine activation, and if it's not adequately treated, it can be as harmful as any disease and may progress to chronic pain. Chronic pain can have severe emotional, physical, and or social stresses on a person and their family. The psychological consequences of pain and the physiological consequences of inactivity. So that nociceptive chronic pain is due to the continuing stimulation of nociceptive receptors. The neurons are normal and they're sending signals of tissue damage appropriately. You have primary hyperalgesia because you have excessive sensitivity to stimuli in the injured tissue. And the nociceptive chronic pain serves a useful biological function as a warning to protect injured tissue. So chronic pain involves inhibitory and excitatory circuits in the central nervous system that either diminish or amplify pain message. So in neuropathic pain, there are those neural mechanisms are amplifying pain signals and creating pain in the absence of noxious stimuli. So it's like the malfunctioning car alarm. There's nothing happening to the car, but the alarm siren is still going. So the neural mechanisms for regulating pain amplify those signals. They create pain in the absence of noxious stimuli. And so sometimes neuropathic pain is a description. Sometimes it's called pain matrix dysfunction. And then we'll talk about in the second part of this chapter specific pain syndromes that involve these pain amplification signals. Pathological pain or neuropathic pain has no beneficial biological function. A lot of times there's no tissue damage, and so there's no need to rest damaged tissues like there is with acute pain. So the International Association for the Study of Pain defines neuropathic pain as pain arising as a direct consequence of a lesion or disease affecting the somatosensory system. So it means that there's actually something wrong with the signals that we're getting. We're transmitting the wrong signals, we're amplifying signals, something is wrong. In nociceptive pain, the neurons are functioning the way they're supposed to. So interestingly enough, there can be a genetic component to chronic pain. So people with genetic codes that produce less of the enzyme that regulates the levels of catecholamine and enkephalin are twice as likely to develop neuropathic pain as those who produce more of the enzyme. So there are some factors that are out of our control. So the symptoms of neuropathic pain are paresthesia. And the definition of paresthesia is painless abnormal sensation in the absence of nociceptor stimulation. So there's nothing going on with the nociceptors, but we have abnormal sensation in the limb. A lot of times this is described as numbness, sometimes tingling, sometimes heaviness, or it just doesn't feel right. That's another description of it. Dysesthesia is an unpleasant, abnormal sensation, either evoked or spontaneous. So paresthesia arises from the dysfunction of neurons, and it's usually tingling, numbness, or prickling sensation. So lesions anywhere along the nociceptive pathways can cause paresthesias. Dysesthesia is typically described as burning pain, shooting pain, or electrical sensations. So it's unpleasant, abnormal sensation. So paresthesia is just abnormal, but not painful. Dysesthesia is sort of painful, abnormal sensation. And so tingling, prickling is paresthesia. Burning, shooting, or electrical sensations is dysesthesia. Both allodynia and secondary hyperalgesia are specific types of dysesthesia that are evoked by stimuli. So allodynia, dynia is another root word that means pain. Algia is the Latin root word for pain, and dynia is the Greek word for pain. So allodynia is pain with a stimulus that is normally non-painful. So the one of the tests for allodynia is you brush someone lightly with a little brush, and if that causes pain, that's allodynia. So it's a normally non-painful stimulus that causes pain. So sunburned skin makes light touch extremely painful, where at some point it can hurt to even have clothes touching your skin. So that is allodynia. Secondary hyperalgesia is excessive sensitivity to stimuli that are normally mildly painful in injured tissue. So like the sharp end of a probe, it's normally mildly painful. In secondary hyperalgesia, it's extremely painful. So excessive pain. So there is a little table in the module that talks about different tests and what the normal response is and what the neuropathic response is. I don't expect you to know that necessarily. I want you to know the definition of these different things. But sometimes looking at the testing gives you a better appreciation of the definition of them. So there are 4 mechanisms that produce neuropathic pain, and we'll talk about each one of these. So lots of different things can cause neuropathic pain. So ectopic foci. Ectopic means it's not in the place where it usually should be, and foci is the plural of focus. So when myelin is damaged, signals from the exposed axons stimulate excessive production of mechanosensitive and chemosensitive ion channels. So our ion channels in our neurons respond to what's going on in our body. So say that you are having an immune response because you were exposed to a flu virus. You might feel achy. Your nerves are being stimulated because the immune system is putting more immune responsive channels into your nerves. So when we have the myelin damage, there are more ion channels that are producing abnormal sensitivity to mechanical and chemical stimuli. So the areas that are the areas where the myelin is damaged are abnormally sensitive to pressure, and it stimulates the dorsal root ganglion, or the somas of the cells that are in the dorsal root ganglion. The demyelinated regions take on the new pathological role of generating action potentials in addition to their normal role of conducting axon potentials. So basically, this is abnormal. We don't want this to happen. So just know that when we're talking about neuropathic pain, it's not a normal response. It's an abnormal, damaged response. Epiphactic transmission is also called crosstalk, and it occurs in demyelinated region. It occurs as a result of a lack of insulation between neurons. You can sort of think of it as an electrical short. So an action potential in one neuron may induce an action potential in a neighboring neuron where it normally wouldn't if the area had its normal myelination. So it's like when a couple of my cats were kittens. They chewed on an electrical cord that was behind the couch. They went back there and chewed on the cord. And so then the light, when you turned on that lamp, the electrical cord was a little shorted and the light would flicker. We couldn't figure out why that happened until we pulled it out from behind the couch and we saw that the insulation had been chewed off. So you can think of epiphactic transmission as the insulation is missing. And so you're getting sort of an electrical short in your neurons. Central sensitization is excessive responsiveness of central neurons. It develops in response to ongoing nociceptive input, but the alterations in the central neural activity outlast the original tissue injury. So you have this ongoing nociceptive input from a tissue injury. The tissue injury heals, but the neurons have already been altered, and so even after the tissue injury is healed, they're in a hypersensitive response state. So intense signals from an injury in the periphery may eventually cause central sensitization if it goes on for a long time. So we talked about how you want to address acute pain so it doesn't become more chronic. So it's an alteration in the central neural activity, and it's disproportionate to nociceptive input. So that's that sensitization part. So in fibromyalgia, it's a little bit of a central sensitization issue. They have an extra sensitive nervous system, so the pain they feel is disproportionate to their nociceptive input. There are actual cellular changes in central sensitization There's increased spontaneous activity, so you don't have to have a stimulus. The nerves just become active. The central sensitization process is similar to long-term potentiation, which is that neuroplastic learning that we talked about in Chapter 7. And but this, unfortunately, this isn't doing us any good. This is hindering our efforts. There's increased responsiveness to afferent input and prolonged after discharge in response to repeated stimuli. So you get a stimulus, and then there's just more response from the central nervous system. And it also causes expansion of receptive fields. So an area that wouldn't normally be evoked by a stimulus, now you have bigger receptive fields, and you're getting more stimulus from the periphery as well. So a lot of cellular changes go on in central sensitization. Structural reorganization results from prolonged central sensitization. It actually rewires your central nervous system connections. So in the dorsal horn, structural changes can include withdrawal of C fiber axon terminals from central nociceptive neurons. So the A beta fibers actually synapse with neurons in the C fiber pain pathway. And so so stimulation of an A beta fiber yields impulses that are perceived as pain rather than the normal non-painful A beta impulses. Well, that stinks, right? So once these new synapses have formed, normal non-painful stimuli will produce impulses that are perceived as pain. So overall, you have initial and ongoing excessive excitability of those central nociceptive neurons. So it really is sort of a bad situation because now you have systems that used to work to reduce pain are now working to increase pain. So neuropathic pain can arise from abnormal neural activity in the periphery, in the central nervous system, or in the dorsal horn. So all of the different areas of our pain pathways basically can be damaged to the point where they are causing abnormal neural activity and increased pain. So injury or disease in peripheral nerves often results in sensory abnormalities. So a complete nerve resection results in the lack of sensation from that nerve's receptive field. So a good example of this is when you have orthopedic surgery, like say you had a knee replacement. Most people, the lateral to the knee replacement incision, they lack sensation in that area. They lack light touch sensation because that nerve was resected. It was cut, basically. It does come back at about 1 millimeter a day, and they will eventually regain sensation from that nerve's receptive field. But after surgery, you'll always hear people say, oh, I can't even feel the touch there. Partial damage can result in allodynia and sensation similar to electric shock. So it can be hypersensitive to stimulus that wasn't painful before, or that dysesthesia, that electric shock zinging sort of pain. Peripheral abnormalities causing neuropathic pain include development of epiphactic transmission, that's that crosstalk, that electrical short, if you want that, occurring in demyelinated regions, epitopic foci in an injured nerve that occurs at the nerve stump in areas of myelin damage or dorsal root ganglion somas. So that's where you're getting the bad, you're getting the excess sensitivity from new ion channels and in areas of myelin damage. So in the central nervous system, deafferentation, meaning you're lacking afferent input, it can be complete or partial. But neurons in the central nervous system may become abnormally active when peripheral sensory information is completely absent. So Avulsion of dorsal roots from the spinal cord produces deafferentation and causes an individual to feel burning pain in the area of sensory loss. So that stinks. You don't even have the peripheral input, but yet you have pain anyway, which is just not fair. It's a lot of times the abnormal response is that pain response. And it's very difficult to deal with. There aren't a lot of medications that address that or a lot of procedures that address that. So phantom pain is a phantom limb sensation, it's also called. It refers to individuals who have had a limb amputated but experience sensations that seem to originate from the missing limb. So the example I have, a friend of my family's was in a car accident and had a below knee amputation. He had really good recovery and had a prosthesis, but he said at the end of the day when he came home from work, his feet hurt. Both of his feet hurt, even the one where he didn't have a foot. So that's that phantom limb sensation. Phantom sensation that is painful is called phantom pain. Reports of this are more rare, and there are different theories about why it may happen. Phantom pain is different from residual limb pain. The treatment for residual limb pain is usually to desensitize the area, the same way we would desensitize an incision or another injury. For phantom pain, a lot of times you have to do something more centrally focused, like graded motor imagery or mirror therapy. So there are therapeutic treatments for phantom pain, but it is something that is quite difficult to treat. Central pain that's caused by a lesion of the central nervous system is usually localized to the area of the body that is deafferented by the lesion. So neuropathic central pain usually refers to burning, shooting, aching, freezing, or tingling pain. In spinal cord injury central pain, the thalamus may be the site of pain generation, because after a spinal cord injury, neurons in the thalamus are spontaneously active without input from the spinal cord. Sometimes people can have a stroke that can cause a thalamic pain syndrome as well. So in multiple sclerosis, a lot of times central pain depends on the individual location of their lesions. Small fiber neuropathy, so peripheral neuropathy, can produce partial deafferentation because you're losing sensation from that area, and it can produce central sensitization in response to that. So post-herpetic neuralgia, diabetic neuropathy, and Guillain-Barré syndrome can cause deafferentation pain due to damage in small diameter C fibers. So a lot of different things can cause that central sensitization, and it is very difficult to treat.